Okay, this reading is for Friday, March the 6th on MS, O'Sullivan Book, and Therapy Ed. So these are pictures from the 6th edition that Final Frontier uses. I use the 7th edition, and so we will do the reading first.
Multiple sclerosis, MS, is a progressive autoimmune disease characterized by inflammation, selective demyelination, and gliosis. It causes both acute and chronic symptoms and can result in significant disability and impaired quality of life. MS affects approximately 400,000 persons in the United States. Worldwide, MS affects approximately 2.1 million people. It was first defined by Dr. John Charcot in 1868 by its clinical and pathological characteristics, paralysis and the cardinal symptoms of intention tremor, scanning speech, and nystagmus, later termed Charcot's triad. Using autopsy studies, he identified areas of hardened plaques and termed the disease sclerosis in plaques. The onset of MS typically occurs between ages 20 and 50 years and is uncommon in children. Only 3% to 5% of all individuals with MS have symptoms begin before the age of 16, although cases as young as 2 years have been reported. The onset of symptoms after the age of 50 occurs in approximately 9% of individuals with MS. The disease is more common in women than in men by a ratio of 1 to 3, but men display a more progressive disease course and more rapid disability. Interestingly, when symptoms occur after age 50, the prevalence is approximately equal for men and women, and approximately half of all individuals experience the progressive form of the disease. Although the incidence and prevalence of MS overall have increased over the past 5 decades, this increase appears to be mostly related to an increased prevalence in women. There are also ethnic differences. MS affects predominantly white populations. African Americans demonstrate approximately half the risk of acquiring the disease. However, African Americans tend to experience a more progressive disease course, have more frequent relapses with less recovery, are more likely to have optic nerve and spinal cord involvement, and are more likely to develop greater disability over the same time period than their Caucasian counterparts. Low rates of MS are also reported in Asians and Native Americans. Epidemiological studies have established a geographical pattern of MS prevalence with areas of high, medium, and low frequency. High-frequency areas include the temperate zones of the northern United States, the Scandinavian countries, northern Europe, southern Canada, New Zealand, and southern Australia. Areas of medium frequency closer to the equator include the southern United States and Europe and the rest of Australia, and low-frequency tropical areas include Asia, Africa, and South America. Migration studies indicate that the geographical risk associated with an individual's birthplace is retained if emigration occurs after age 15 years. Individuals migrating before this age assume the risk of their new location. Etiology: the risk of developing MS in the general population is 0.1%, while the risk of MS is increased in persons with an affected family member. The risk is 2% for a child of a person with MS, 5% for a sibling or a fraternal co-twin of a person with MS, rising to 25% for an identical co-twin. Genetic studies have revealed more than 100 interacting alleles that may contribute to MS susceptibility, with mutations in the human leukocyte antigen major histocompatibility complex, MHC, gene most strongly correlated. It appears that although individuals do not inherit the disease, they may inherit the genetic susceptibility to immune system dysfunction. When persons with a genetic susceptibility are exposed to a viral agent, the immune system responds with activated myelin-reactive lymphocytes, a concept known as molecular mimicry. Implicated viruses in this process under investigation include the Epstein-Barr virus, measles, canine distemper, human herpes virus 6, and chlamydia pneumoniae, though none have been definitely proven to trigger MS. The viruses may be retained in the body, resulting in a self-perpetuating autoimmune process. Risk of MS may also be increased with vitamin D deficiency and smoking. Pathophysiology: in patients with MS, an abnormal immune-mediated response attacks the myelin nerve coating, the oligodendrocytes, myelin-producing cells, and the nerve fibers themselves in the central nervous system, CNS. The response triggers activation of immune cells, For example, selective activation of helper T cells on killer T cells, with a corresponding decrease in regulatory T cells, and B cell activation that cross the blood-brain barrier, entering the CNS and initiating a damaging inflammatory cascade of events, the outside-in model. Recently, the inside-out model has been proposed, in which oligodendrocyte damage and loss occur first, which then triggers immune attacks and inflammation. Along with inflammation and phagocytic activity of macrophages, mitochondrial damage is thought to contribute to demyelination, oligodendrocyte loss and axonal damage. Myelin serves as an insulator, speeding up the conduction along nerve fibers from one node of ranvier to another, termed saltatory conduction. It also serves to conserve energy for the nerve because depolarization occurs only at the nodes. Disruption of the myelin. Sheath and active demyelination slows neurotransmission and causes nerves to fatigue rapidly. With severe disruption, conduction block occurs with resulting disruption of function. The acute inflammatory attack on myelin gradually subsides, contributing to the pattern of fluctuations in function that characterize this disease. Relapses, defined as periods of acute worsening of neurological function, and remissions, defined as periods without disease progression and partial or complete abatement of signs and symptoms. With repeat attacks, the anti-inflammatory processes become less effective and are unable to keep up. During the early stages of MS, oligodendrocytes survive the initial insult and can produce remyelination. This process is often incomplete and, as the disease becomes more chronic, stalls altogether. When the oligodendrocytes become damaged, myelin repair cannot occur. One form of MS, primary progressive MS, in which relapses and remissions do not occur, appears to be closely associated with oligodendrocyte damage and neurodegeneration. Demyelinated areas eventually become filled with fibrous astrocytes and undergo a process called gliosis. Gliosis refers to the proliferation of neuroglial tissue within the CNS and results in glial scars, plaques. The axon itself becomes interrupted, undergoes neurodegeneration, and is believed to be the main cause of permanent neurological disability. It has long been thought that MS progresses in a two-stage process. Inflammatory damage with associated demyelination and some axonal damage is the first stage, and degenerative changes including axonal and oligodendrocyte destruction is the second stage. Recent studies suggest that rather than two distinct sequential stages, both neuroinflammation and neurodegeneration may occur simultaneously. In advanced cases of relapsing remitting MS and earlier in progressive forms of MS, there are both acute and degenerative lesions of varying size scattered throughout the CNS, brain, brainstem, cerebellum, and spinal cord. Lesions primarily affect white matter early, with lesions of gray matter evident in more advanced disease. Lesions may also include small perivascular areas of demyelination and pale surface lesions. Brain atrophy, the loss of axons and myelin throughout the brain, is evident even in early stages of the disease and is progressive. There are certain areas of predilection, such as the optic nerves, periventricular white matter, spinal cord, corticospinal tracts, posterior white columns, and cerebellar peduncles. Disease course MS is highly variable and unpredictable from person to person and within a given individual over time. In 1996, the U.S. National Multiple Sclerosis Society, NMSS, Advisory Council on Clinical Trials in Multiple Sclerosis defined the clinical course descriptions, phenotypes of multiple sclerosis. The NMSS gave standardized definitions for 4 MS clinical courses: relapsing remitting, RA, secondary progressive, SP, primary progressive, PP, and progressive relapsing, PIA. These phenotype descriptions were intended to represent the spectrum of MS subtypes, but were based on subjective views of the time and lacked objective biological supports that are now available. These descriptions of MS phenotypes were revised in 2013, maintaining the basic features of the original descriptions, with clarifications and modifications, eliminating the PIA-MS subtype. A new disease course was added in the 2013 revisions, clinically isolated syndrome, CIS, not included in the 1996 clinical descriptors, refers to a first episode of inflammatory demyelination in the central nervous system that could become MS if additional activity occurs. CIS can be further characterized as not active, No clinical relapses or new MRI activity, or active, with relapses and/or evidence of new MRI activity, in which case it becomes relapsing remitting MS. Relapsing remitting MS, RRMS, is the most common course, affecting approximately 85% of patients with MS. It is characterized by discrete attacks or relapses followed by remissions and can also be further characterized as active or not active. Most people diagnosed with RRMS will eventually transition to secondary progressive MS, SPMS. SPMS begins with a relapsing remitting course followed by progression to steady and irreversible worsening of neurologic function and accumulation of disability. As with CIS and RMS, SPMS can be further characterized as either active or not active, but is also characterized as with progression, evidence of disease worsening on an objective measure of change over time, with or without relapses, or without progression, referring to progressive accumulation of disability. Primary progressive MS, PPMS, is a less common form occurring in about 15% of cases. It is characterized by a nearly continuous worsening of the disease from the onset without distinct attacks and is further characterized as active or not active and as with progression or without progression. Because the course of the disease may alter, RRMS to SPMS, clinicians need to be alert to changes in signs or symptoms in terms of severity, frequency, and impact on function. The 1996 category of progressive relapsing MS is eliminated since. These patients are now classified as PPMS with disease activity. Box 16.1 summarizes the 1996 disease course definitions and the 2013 revisions of disease course, or clinical subtype of multiple sclerosis. Exacerbating factors MS relapses, exacerbations, are defined by new and recurrent MS symptoms lasting more than 24 hours but generally of longer duration that are unrelated to another etiology. Several exacerbating factors have been identified. Avoiding these factors is important in ensuring the patient's optimal function. An individual whose overall health deteriorates is more likely to have a relapse than one who remains healthy. Viral or bacterial infections, for example, common cold, influenza, urinary tract infection, sinus infection, and diseases of major organ systems, for example, hepatitis, pancreatitis, asthma attacks, are associated with relapses of disease. There is also a modest link between stress and acute attacks. Both major stresses, divorce, death, job loss, trauma, and minor stresses, exhaustion, dehydration, malnutrition, and sleep deprivation, can affect the immune system and an already compromised nervous system. Pseudo-exacerbation refers to the temporary worsening of MS symptoms. The episode typically comes and goes quickly, usually within 24 hours. The overwhelming majority of individuals with MS demonstrate an adverse reaction to heat, known as a HOF symptom. Anything that raises the body temperature can bring on a pseudo-attack. External heat stressors included sun exposure, hot muggy environmental temperatures, or a hot bath. Internal elevations in temperature can be produced by fever or prolonged exercise. However, studies indicate exercise is a safe and essential component of health for individuals with MS. The effects are usually immediate and dramatic in terms of reduced function and increased fatigue. Most pseudo-attacks resolve within 24 hours of cooling off and/or the end of the fever symptoms. Symptoms of MS vary considerably, depending on the location of specific lesions within the central nervous system. Early symptoms typically include minor visual disturbances, for example, episodes of double vision, and paresthesias progressing to numbness, weakness, and fatigability. In more advanced stages, patients demonstrate multiple symptoms with varying involvement. Common MS symptoms are presented in box 16.2. The onset of symptoms can develop rapidly over a course of minutes or hours. Less frequently, onset is insidious, occurring over a period of weeks or months. Early remission may lead the individual to postpone initial neurological workup for months or longer. Sensory complete loss of any single sensation, anesthesia, is rare. Focal deficits can produce limited areas of diminished sensation. Altered sensations are far more common and can include paresthesias, pins and needles sensation, or numbness of the face, body, or extremities. Disturbances in position sense are also common. has a lower extremity impairments of vibratory sense. Pain. Approximately 80% of patients with MS experience pain, with clinically significant pain occurring in about 55% of individuals, and almost half experience chronic pain. Patients often experience acute paroxysmal pain characterized by sudden and spontaneous onset. The pains are described as intense, sharp, shooting, electric shock-like, and burning. The most common types are trigeminal neuralgia, paroxysmal limb pain, and headache. Trigeminal neuralgia, tic-dowler roots, results from demyelination of the sensory division of the trigeminal nerve innervating the face, cheek, and jaw. Eating, shaving, or simply touching the face may trigger painful episodes. A common sign of posterior column damage in the spinal cord is the hermit sign, in which flexion of the neck produces an electric shock-like sensation running down the spine and into the les. Paroxysmal limb pain presents as abnormal burning, aching pain, dysesthesias, that can affect any part of the body but is more common in the les. It is the most common type of pain in MS and is often worse at night and after exercise. It can be aggravated by temperature elevations. Hyperpathia, a hypersensitivity to minor sensory stimuli, can occur. For example, a light touch or light pressure stimulus elicits a severe pain reaction. Headache is more frequent in MS than in the general population and can be migraine or tension type. Chronic neuropathic pain can result from demyelinating lesions in spinothalamic tracts or in the sensory roots. It is more common in patients with minimum disability and is described as a burning, aching, pins and needles pain similar to pain described by individuals with disc herniation. Musculoskeletal pain associated with muscle and ligament strain can develop from mechanical stress, abnormal postures, and immobility, often the result of weak muscles, powerful spasticity, and tonic spasms. Anxiety and fear can worsen pain symptoms. Visual symptoms are common with MS and are found in approximately 80% of patients. Involvement of the optic nerve produces altered visual acuity. Blindness is rare. Optic neuritis, inflammation of the optic nerve, is a common problem and produces an aspect-like pain behind the eye with blurring or graying of vision or blindness in one eye. A scotoma or dark spot may occur in the center of the visual field. Neuritis rarely affects both eyes and is usually self-limiting. Vision generally improves within 4 to 12 weeks. Damage to the optic nerve will also affect light reflexes. Relative afferent pupillary defect, or apidemocus subpupil, often develops in individuals with MS who have had an episode of optic neuritis. Shining a bright light into the healthy eye will produce reflex contraction in both eyes, consensual light reflex. If the light is then shone in the affected eye only, a paradoxical widening, dilation of both pupils occurs. Eye movements can be disturbed in a variety of ways. Nystagmus is common in patients with MS and results from lesions affecting the cerebellum or central vestibular pathways. This involves involuntary and rapid cyclical movements of the eyeball, horizontal and vertical, that develop when the patient looks to the sides or vertically, gaze-induced nystagmus, or when the patient moves the head. Internuclear ophthalmoplegia, INO, produces incomplete eye adduction, lateral gaze palsy, on the affected side and nystagmus of the opposite abducting eye with gaze to one side. It is caused by demyelination of the pontimedial longitudinal fasciculus, MLF. Additional impairments in conjugate gaze and control of eye movements may also be present with brainstem lesions affecting cranial nerves 3, IV, and 6 or the MLF. Diplopia, double vision, occurs when the muscles that control the eyes are not well coordinated. Visual disturbance is frequently remittent and is seldom the primary cause of disability. The effects of impaired vision on balance and movement should be carefully examined. Motor patients with corticospinal lesions demonstrate signs and symptoms of upper motor neuron syndrome, paresis, spasticity, brisk tendon reflexes, involuntary flexor and extensor spasms, clonus, Babinski's sign, exaggerated cutaneous reflexes, and loss of precise autonomic control all characterize involvement. See discussion in Chapter 5. Examination of motor function, motor control and motor learning. Weakness patients with syndrome demonstrate movements that are slow, stiff, and weak. The result of loss of orderly recruitment and reduced firing rate modulation of motor neurons. Reduced muscle strength, power, and endurance, along with impaired synergistic relationships, are evident. Patients with cerebellar lesions demonstrate asthenia or generalized muscle weakness along with ataxia. Patients can also experience muscle weakness secondary to inactivity. Muscle weakness can vary from a mild paresis, often transient at first, to total paralysis of the involved extremities. Spasticity is an extremely common problem in patients with MS. Spasticity can range from mild to severe, depending on the duration of the disease, number of relapses, and worsening symptoms in recent months. It occurs in the muscles of the upper extremities, UEs, and particularly the LES. Clinical indications of spasticity include impaired voluntary control of movement, abnormal co-contraction, increased deep tendon reflexes, DTRs, clonus, and decreased range of motion, ROM. Spasticity also results in increased fatigue, impaired functional mobility, and impaired activities of daily living, ADL. Spasticity can cause pain, disabling contractures, abnormal posturing, problems in maintaining skin integrity, and falls. For some patients, spasticity can be beneficial to sitting and standing, acting to support weak musculature. Spasticity fluctuates on a daily basis and can be exacerbated by certain factors, such as fatigue, stress, overheating, fever, environmental, cold temperatures, infections, or noxious stimuli, for example, pain, bladder, renal, bowel, skin lesions injury. Certain antidepressant agents, serotonin reuptake inhibitors such as fluoxetine, sertraline, and paroxetine, can exacerbate spasticity. Spasticity does not typically abate during spontaneous remissions. In patients with advanced disease, spasticity can be quite disabling and difficult to manage. Fatigue is a frequent and often disabling symptom of MS. The definition of fatigue differs widely among patients, physicians, and researchers, typically reported by patients as feelings of overwhelming tiredness, exhaustion, and weakness together with difficulty concentrating and mental dullness. Fatigue in MS may onset abruptly without warning and typically worsens throughout the day. A large majority of patients report that fatigue is one of their most troubling symptoms and consistently report that fatigue interferes with physical functioning, overall role performance, social participation, and perceived health status. Despite its prevalence, the pathophysiology of fatigue in MS is still not completely understood. A recently proposed definition and model of fatigue is a decrease in physical and/or mental performance that results from changes in central, psychological, and/or peripheral factors. These changes depend on the task being performed, the environment, and the individual's mental and physical capacity. Central factors contributing to fatigue in MS include inflammation, axonal conduction velocity, imbalance of neurotransmitter levels, and decreased cerebral glucose metabolism. Psychological factors included perceived effort, self-efficacy, motivation, and cognitive impairment. Peripheral factors of fatigue in MS involve slowed contractile properties and decreased metabolic response of muscles. A patient's level of fatigue can be influenced by physical exertion, exposure to heat and humidity, disturbed or reduced sleep, depression, anxiety, cognitive impairment, and medical conditions, for example, respiratory infection. Side effects of medications also affect fatigue, including analgesics, anticonvulsants, antidepressants, antihistamines, antihypertensive agents, and anti-inflammatory agents. Coordination and balance demyelinating lesions in the cerebellum and cerebellar tracts are common in MS, producing cerebellar symptoms. Clinical manifestations include ataxia, postural and intention tremors, hypotonia, and truncal weakness. Ataxia is a general term used to describe uncoordinated movements characterized by dysmetria, dysenergia, and dysdidatrokinesia. Progressive ataxia of the trunk and legs is often apparent during sitting or standing, when a limb or the body must be supported against gravity. The patient typically presents with postural tremor, shaking, back and forth oscillatory movements. Intention, action, tremors are involuntary, rhythmic, shaking movements that occur when purposeful movement is attempted and results from the inability of the cerebellum to dampen motor movements. See Chapter 6. Examination of coordination and balance. Tremors vary in severity from slight, barely perceptible quivering, fine tremor, to wide oscillations, gross tremors. Severe tremors impose significant limitations in performance of functional activities, particularly in such areas as eating, speaking clearly, writing, personal hygiene, and walking. Tremor can be exacerbated by stress, excitement, and anxiety, all adrenaline-releasing conditions producing a temporary aroused condition. 20. Severe numbness of the feet can contribute to difficulty with standing balance or walking. Sensory ataxia. Lesions affecting the cerebellum or central vestibular pathways can produce vestibular dysfunction. Patients may experience symptoms of dizziness, disequilibrium, vertigo, and nausea. Symptoms are precipitated or made worse by movements of the head or eyes. See Chapter 21. Vestibular disorders. Gait and mobility. Individuals with MS experience difficulty walking as a result of muscle weakness, fatigue, spasticity, impaired balance, impaired sensation, visual problems, and ataxia. Approximately half of patients with MS will require some form of assistance during walking within 15 years of their diagnosis. Weakness in one or both legs may result in asymmetric step lengths and increased variability of gait, while severe extensor spasticity may produce a scissoring gait pattern, staggering, uneven steps, poor foot placement, uncoordinated limb movements, and frequent loss of balance characterize ataxic gait. It is often mistaken for drunkenness, a finding that frequently results in the patient revealing the disease for the first time. Gait and balance impairments increase the risk of falls and fall injury. Approximately half of patients with MS report recent falls. Fear of falling is associated with self-imposed restrictions in mobility and contributes to disability and social isolation. Safe and goal-oriented walking requires higher-level cognitive processing, highlighting the strong relationship between cognitive function and gait. Deficits in both walking and cognitive function are common in MS. These impairments are compounded when performing walking and cognitive tasks simultaneously. Dual tasking, referred to as cognitive emitter interference, CMI. While walking performance declines in people with MS as a result of CMI, a recent systematic review and meta-analysis of 13 studies found only minimal difference in the CMI between individuals with and without MS. Speech and swallowing. Speech problems are the result of muscle weakness, spasticity, tremor, or ataxia. As many as 44% of individuals with MS experience impairment of speech or voice after disease onset. Dysarthria is characterized by slowed or poorly articulated speech with low volume, unnatural emphasis, and slow rate. Dysphonia is characterized by changes in vocal quality including harshness, hoarseness, breathiness, or hypernasal sounds. Poor coordination of the tongue, oral, and pharyngeal muscles can also result in dysphagia, difficulty in swallowing. Signs of swallowing dysfunction include difficulty chewing and maintaining a lip seal, inability to swallow, ingest food, and spitting or coughing or throat clearing during or after meals. Aspiration pneumonia is a serious complication that can develop if foods or liquids are inhaled into it or clear. Signs of aspiration include coughing or throat clearing after intake. Wet voice quality with gurgling or sounds of congestion, and fever. The patient is also at risk for poor nutritional intake and dehydration and may experience weight loss. Poor coordination of breath control and posture contributes to speech and feeding difficulties. Cognitive impairment is common in MS and may appear in either early or later stages of the disease, with prevalence rates of up to 70%. Multiple aspects of cognition are impacted by MS, most commonly in decreased information processing speed. Other deficits in selective cognitive domains included impaired attention and concentration, executive functioning, concept formation, abstract reasoning, problem solving, planning, and sequencing, visuospatial functions, verbal fluency, and working memory, overall intellectual functioning, long-term memory, conversational skills, and reading comprehension are typically intact. Cognitive impairments are related to the specific locations and total volume of the lesions, cerebral atrophy, third ventricle width, and corpus callosum size. With increasing lesion load over time, neuroplastic changes occur to compensate and maintain cognitive function, that eventually are ineffective. Cognitive function is not associated with overall severity of the disease, its course, or the patient's disability status. Focal frontal lobe lesions can produce cognitive inflexibility and poor impulse control. Secondary factors that can influence cognition include depression, anxiety, fatigue, medications, and comorbid conditions, for example, Cardiovascular or cerebrovascular disease. Level of cognitive dysfunction is a major factor in determining quality of life, social functioning, employment status, and function. Depression is a common symptom of MS, indeed major depressive disorder. The most severe form occurs in up to 50% of individuals. The age standardized incidence of depression is 71% higher and prevalence is roughly 10% higher than in the matched population. Inflammation may be a contributing factor to depression in MS, as individuals with other neuroinflammatory diseases, such as inflammatory bowel disease and rheumatoid arthritis, also experience depression at similar rates to individuals with MS. Depressive symptoms can include feelings of hopelessness or despair, diminished interest or pleasure in activities, changes in appetite and significant weight loss or gain, insomnia or hypersomnia, daytime sleepiness, feelings of lethargy or worthlessness, fatigue or loss of energy, decreased concentration, and recurrent thoughts of death and suicide. Depression can occur from a complex interaction of pathological processes in MS, a pre-existing or predisposition to a mood disorder as a side effect of some drugs, for example, corticosteroids, interferon, as a psychological reaction to the stresses of this far-reaching and unpredictable disease, and normal grieving of the losses associated with MS. Other mood disorders also occur more frequently in MS. The prevalence of anxiety disorders is up to 36%, adjustment disorder is up to 22%, and bipolar disorder, alternating periods of depression and mania, is up to 13%. Denial, anger, aggression, and substance abuse can also occur. Patients with MS face enormous issues related to the ambiguity of their health status, the unpredictable course of disease activity, unpredictable future status, and the loss of effective functioning during the prime of their lives. Emotional affective disorders in MS occur as a direct result from effects of the disease on the brain and can include changes in mood, feelings, emotional expression, and control. Pseudobuber affect, PBA, also known as involuntary emotional expression disorder or emotional incontinence, occurs in about 10% of people with MS and is characterized by sudden and unpredictable episodes of crying, laughing, or other emotional displays. PBA may occur when the disease damages the area of the brain that controls normal expression of emotion, including the limbic system and paralimbic networks. Euphoria is an exaggerated feeling of well-being, sense of optimism incongruent with the patient's incapacitating disability, which is less common and can occur in more advanced MS or with significant cognitive changes. Apathy is the lack of motivation affecting cognitive, emotional and behavioral domains, which occurs in MS with a prevalence of up to 40% and is correlated to more severe cognitive dysfunction. Urinary bladder dysfunction occurs in about 80% of patients. Demyelinating lesions affecting the lateral and posterior spinal tracts unmask the sacral reflex arc, producing loss in volitional and synergistic control of the micturition reflex. Types of bladder dysfunction in MS can include a small, spastic bladder, a failure to store problem, a flaccid or big bladder, a failure to empty problem, or a dysenergic bladder. The dysenergic bladder represents our problem with coordination between bladder contraction and sphincter relaxation. Common symptoms include urinary urgency, urinary frequency, hesitancy in starting urination, nocturia, frequency at night, dribbling, and incontinence. The severity of bladder symptoms is associated with severity of other neurological symptoms, particularly pyramidal tract involvement, progressive loss of functional mobility, for example, and skills, sitting balance and transfer skills, ambulation, contributes to personal hygiene problems, emotional distress, and functional incontinence, inability to toilet or manage dysfunction. Emptying dysfunction with large residual urine volume increases the risk of recurrent urinary tract infections, UTIs, and kidney damage from frequent UTIs. Bowel constipation is the most common bowel complaint in MS and results from lesions affecting control of the gastrocolic reflex. It is associated with the presence of spasticity of the pelvic floor muscles and is also a frequent consequence of inactivity, lack of fluid intake, poor diet and bowel habits, depression, and medication side effects. Bowel impaction is a serious complication that requires immediate attention. Diarrhea and incontinence are less problematic but can also occur as a result of loss of rectal control, sphincter abnormalities, or other secondary problems, For example, gastroenteritis, inflammatory bowel disease, medication side effect. Sexual dysfunction is common, affecting as many as 91% of men and 72% of women. In women, symptoms can include changes in sensation, vaginal dryness, trouble reaching orgasm, and loss of libido. In men, symptoms can include erectile dysfunction, decreased sensation, difficulty or inability to ejaculate, and loss of libido. Sexual activity is also affected by the appearance of other symptoms such as spasticity, uncontrollable spasms, pain, weakness and fatigue, bladder or bowel incontinence, losses in functional mobility, and changes in self-image. Psychological factors have a large impact on function. Sexual dysfunction has tremendous functional and psychosocial implications for both patient and partner. Management of fatigue, with approximately 75% of individuals with MS describing persistent or sporadic symptoms. Fatigue is among the most debilitating.
Okay, we have to move to a different area of the book. So let's see. They went from 669 to 691. So book, you go here. 691. And start right there at fatigue.
Fatigue is characterized by overwhelming sleepiness, excessive tiredness, and sense of weakness that comes on suddenly and severely. Aversion to activity for fear of bringing on fatigue is also common. The resultant lowered activity levels have important implications for diminished health status and deconditioning. Therapists are faced with a balancing act, on one hand prescribing exercise, while on the other hand avoiding overwork and the development of fatigue. Aerobic exercise training, previously discussed, and energy effectiveness strategies, are central to any intervention plan to lessen fatigue. During exercise prescription and physical therapy sessions, it is imperative that a skilled therapist recognize the difference between MS-related fatigue and the expected exercise-related fatigue. MS-related fatigue during exercise is often associated with thermal stress, which can be offset with adequate rest and the use of cooling and pre-cooling treatments during exercise. Patients are instructed to keep an activity diary in which they record how they slept the night before, daily activities by hour, and how costly those activities were. For each activity, they can be asked to rate their level of fatigue, F, value or importance of the activity, B, and satisfaction perceived with performance of the activity, S, by assigning a number between 1 and 10, with 1 being very low and 10 being very high. For example, the activity might be fixing lunch. Scores reported for this activity might be F equals 7, V equals 3, and S equals 2. Aggravating factors associated with increasing fatigue, for example, heat stress, and MS symptoms that appear or worsen during the day are also recorded. An MS daily activity diary is available online at http://www.hale.ku.edu. Based on this information, therapists can initiate training sessions, teaching energy effectiveness strategies. Energy conservation refers to the adoption of strategies that reduce overall energy requirements of the task and overall level of fatigue. These can include modifying the task or modifying the environment to ensure successful completion of daily activities. For example, a motorized scooter or powered wheelchair can be considered for community or home mobility to help conserve energy and maintain independence. Other mobility equipment such as walkers, crutches, or orthotics can also be considered. Activities that are difficult or have high energy needs can be broken down into component parts, requiring accurate activity analysis. Activity pacing refers to the balancing of activity with rest periods interspersed throughout the day. For the patient with chronic fatigue, rest-activity ratios are developed, with periodic rest periods planned in advance. Timeouts with complete rest should be instituted if an activity becomes exhaustive. Overall levels of energy can be improved if patients learn to set priorities and limit their activities, saving their energy for those activities that are truly important to them. For example, activities that are enjoyable and meaningful in terms of the individual's lifestyle. The occupational therapist addresses these and can provide valuable suggestions in terms of planning, work simplification, and developing energy-efficient activities for self-care and home management. A vocational rehabilitation counselor can provide useful strategies for behavioral modification and vocational rehabilitation. Team efforts with the physical therapist and others are important for consistency and reinforcement. Weekly review of activities and recommended modifications is used to evaluate progress. PMFIS should be administered on a regular basis to monitor ongoing fatigue status. Finally, stress management techniques are important components of symptom management. The occupational and physical therapist should complete a direct environmental examination of the home and/or job site. See Chapter 9, Examination and Modification of the Environment. A number of adaptations may be considered to improve efficiency and safety, including air conditioning, home or work modifications, or ergonomic equipment. The patient family caregiver should be educated as to the importance of these recommendations for improved function. Periodic review of equipment and environmental modifications is also recommended. Additional referrals or collaboration with neuropsychology may also be useful to combat fatigue. Recent work suggests that behavioral interventions may also improve fatigue in persons with MS. Proper communication between the occupational and physical therapist and the patient's physician can ensure that the correct doses of the pharmacological treatments are in place, as the therapist has the unique opportunity of observing the patient in various circumstances and activity levels. Management of spasticity. Although spasticity varies greatly from person to person, muscles that typically demonstrate strong tone include the anti-gravity muscles. For example, in the legs, the quadriceps, hip adductors, and plantar flexors are often spastic, while in the US the elbow.
Okay, and that is where the PDF ended. So that's where I ended my reading. Right? Or no? No. Hold on. Pause. Resume.
Wrist and finger flexors together with shoulder adductors are spastic. Individuals with MS typically demonstrate stronger spasticity in the legs than the US. Spasticity is functionally limiting and contributes to the development of a number of secondary impairments such as contractures, postural deformity, and decubitus ulcus. A variety of physical therapy interventions can be used, including cryotherapy, hydrotherapy, therapeutic exercise, stretching, positioning, or any combination thereof. The responses to these interventions must be monitored closely and carefully balanced with pharmacological interventions. The therapist must closely monitor the effects of the antispasticity medications prescribed and optimize physical therapy interventions with the dosing cycle. For example, patients on baclofen will respond better to stretching techniques if they are applied in the middle of the dosing cycle rather than at the end or beginning. Physical therapists must also recognize contributing factors that affect tone and respond appropriately. For example, infection or fever that increases tone may require a referral to the physician. It is important to reduce or eliminate all factors that can aggravate spasticity, for example, heat, humidity, stress, topical cold, ice packs or wraps, or hydrotherapy, cool bath, can temporarily reduce spasticity by decreasing tendon reflex excitability and clonus and by slowing conduction of impulses in nerves and muscles. The effects of cryotherapy are relatively short-lived, although some patients may experience enhanced ability to move that lasts for minutes or hours. It is important to remember that some patients, particularly those with intact sensation, may react to the unpleasant sensation of cold with fight or flight, or autonomic nervous system responses, such as increased itch, increased aura, or nausea. Cryotherapy is contraindicated in these patients. Stretching and ROM exercises begun early in the course of the disease and continue daily can help patients maintain joint integrity and mobility in the presence of spasticity. Combining stretching with movements using rhythmic rotation, gentle rotation of the limb, or proprioceptive neuromuscular facilitation, PNF, stretching techniques, hold relax active contraction, 8 to AC, contract relax active contraction, crack, is effective in gaining ROM. See Chapter 10, Strategies to Improve Motor Function, for a discussion of these techniques. Maintained stretch, held for 30 minutes to 3 hours, also can be used to decrease stretch reflex activity. Maintained stretch can be achieved with prolonged positioning, for example, tilt table standing with toe wedges, low load, weights applied using skin traction, or serial casts. Air splints also provide an effective mechanism to maintain limbs in lengthened, out of spasticity positions. Patients, family members, clients should be taught stretching exercises as part of a home exercise program. HEP, fast, ballistic stretching movements are contraindicated because spasticity is velocity sensitive. Stretching movements need to proceed slowly to gradually achieve the desired range. Active exercises at slow or self-selected speed should focus on expanding the available ROM. Emphasis on contracting the antagonist muscles can assist through mechanisms of reciprocal inhibition. Electrical stimulation of muscles antagonist to the spastic muscles can also be used to decrease spasticity. Movements that encourage abnormal posture should be discouraged. Patients with abnormal co-contraction may benefit from exercises focused on improving motor control, timing exercises, or biofeedback. Tai Chi, yoga, and aquatic exercises combined with cool water temperatures, less than 85 degrees Fahrenheit, 29.44 degrees Celsius, can also be helpful in producing desired relaxation. 12 functional activities aimed at reducing tone should concentrate on trunk and proximal segments, because many patterns of hypertonus seem to be fixed from the action of the stronger proximal muscles. Extensor tone seems to predominate, so activities that stress flexion with trunk rotation are generally the most effective. For example, lower trunk rotation, LTR, in hood line can be effective in reducing proximal extensor tone. One very effective strategy is to position the patient in hood line with a therapy ball under the flexed legs and gently rock the ball back and forth. Moving from quadruped position to side sitting can also be effective in reducing extensor tone in some patients, as the activity combines LTR with prolonged inhibitory pressure on the quadriceps. For the patient with limited functional mobility, EDSS levels of 7.0 or above, positioning out of abnormal spastic postures is an important component of the management program. In general, prolonged or static positioning in any fixed posture can be deleterious to the patient with strong spasticity and should be avoided. For example, the patient who remains in bed all day with the legs positioned in extension, adduction, and plantarflexion may be unable to flex enough at the hips and knees to sit in a wheelchair. Similarly, the feet will remain fixed in plantarflexion and cannot be positioned on the footrests. A positioning schedule using varied positions, in bed, chair, or wheelchair, will help keep the patient from getting stuck in any one posture. Mechanical positioning devices, for example, resting splints, toe spreader, finger spreader, ankle splint, are helpful in maintaining position and preserving joint structures. Management of coordination and balance deficits, cerebellar deficits, ataxia, postural instability, are common in MS. Impairments in somatosensory, visual, vestibular systems are also common and can significantly impair coordination and balance. Spasms and muscle weakness can affect balance by changing the force and sequence of muscle contraction. These combined effects result in difficulty in sustaining upright postures, walking, and other functional activities, leading to an increased risk of falls. Interventions directed at promoting postural control should first focus on static control, holding, inward bearing, anti-gravity postures, for example, sitting, quadruped, kneeling, modified plantigrade, and standing. Progression through a series of postures is used to gradually increase postural demands by varying the base of support, BOSS, raising the center of mass, COM, and increasing the number of body segments, degrees of freedom. That must be controlled. Specific exercise techniques that can be used to promote stability include joint approximation applied through proximal joints, shoulders or hips, or spine, and rhythmic stabilization, PNF, Patients with significant ataxia will not be able to hold steady and may benefit from the application of the technique of PNF dynamic reversals, slow reversals, progressing through decrements of range. Dynamic postural control can be challenged by incorporating activities such as weight shifting and UE reaching, figure 16.5, or la stepping. In sitting, combining UE movements with trunk movements, flexion with rotation and extension with rotation, is an excellent activity. This can be progressed to more advanced dynamic activities with the patient sitting on a therapy Swiss ball as opposed to sitting on a hard, flat surface, figure 16.6. Core musculature is engaged while the demands on ankle and knee musculature are minimized. This allows for a more focused core balance program that can progress to standing. An important goal of therapy is to promote safe and functional balance. Effective training should involve a variety of everyday functional tasks that challenge balance. Figure 16.7 demonstrates a dynamic postural control activity of combined stepping and reaching. Figure 16.8 demonstrates sit-to-stand movement transitions. As training progresses, tasks are modified, for example, wide base to narrow base to tandem stance, stable surface to movable surface, to promote adaptation of skills. Sensory contexts are also varied to promote adaptive control in various different perceptual contexts. For example, eyes open to eyes closed, firm surface to thick firm surface. Patients with MS and central vestibular dysfunction may benefit from vestibular rehabilitation to improve impaired balance and disability due to dizziness or disequilibrium. Figure 16.9. See Chapter 21, Vestibular Disorders, for additional discussion. The pool is an important therapeutic medium to practice static and dynamic postural control in both sitting and standing, as well as walking. Water provides graded resistance that slows down the patient's ataxic movements, while the buoyancy aids in upright balance. Water aerobics have been shown to be effective in improving strength, decreasing muscular fatigability, increasing endurance, and improving overall fatigue and quality of life in patients with MS. When recommending aquatic exercise programs, it is imperative to assess the individual's tolerance to heat. It is commonly recommended that persons with MS exercise in a pool that is 80 degrees to 85 degrees Fahrenheit, 26.66 degrees to 29.44 degrees Celsius.
Okay, that's the end of the reading. And I clipped out some of the boxes for major clinical subtypes of MS. Let's see what time we are here. 52 minutes. Okay. Relapsing remitting disease with full recovery from relapses with sequelae, residual deficit after incomplete recovery. You have the progressive degrees of primary progressive PPMS, progressive accumulation of disability from onset, with or without temporary plateaus, minor remissions, and improvements. Then you have secondary progressive SPMS, progressive accumulation of disability after initial relapsing course, with or without occasional relapses and minor remissions. Progressive relapsing PRMS, progressive accumulation of disability from onset, but clear acute clinical attacks with or without full recovery. So that was the 1996 MS clinical description subtypes. 1996 up here. And this is the difference between the 6th and the 7th edition. The 6th edition, oops. No, don't do that. Let's see if I can find it. It has box 16.1, 4 major clinical subtypes. It just has the relapsing remitting, secondary progressive, primary progressive, and progressive relapsing. Then in the new 7th edition, It shows the 1996 illness clinical description types, which is the relapsing remitting, primary progressive, secondary progressive, and progressive relapsing. Then it also shows the 2013 illness disease modifiers phenotypes. Clinically isolated syndrome, not active, active. Relapsing remitting disease, not active, active. And then you have progressive disease, which is the primary progressive and the secondary progressive. The primary progressive, progressive accumulation of disability from onset, active and with progression, active but without progression, not active but with progression, not active and without progression, stable disease. The secondary progressive, you have progressive accumulation of disability after initial relapsing course. So the difference between primary progressive and secondary progressive on the first bullet point after the title, progressive accumulation of disability. That's the same. And then it says from onset. And that's primary, from onset. The secondary progressive is after initial relapsing course. Okay. And then you have active and with progression, active but without progression, not active but with progression, not active and without progression, stable disease. So the main difference with the 2013 illness disease modifiers phenotypes, you have primary progressive is from onset, progressive accumulation of disability from onset, primary progressive. Okay. The secondary progressive is progressive accumulation of disability after initial relapsing course. And those are the differences between the 6th edition and the 7th edition. Okay, let's go here. What do we have here? Okay, there I was making my point. I just blew up the 6th edition, and then I blew it up. And then here's the 7th and the 6th edition. Common symptoms of MS. They look to be duplicated. Cognitive symptoms are a little different. It's like this is the old edition, the 6th edition, and this is the new edition. And the cognitive symptoms are longer than in the 6th edition. We have short-term memory deficits, but over here on the 7th edition, we have difficulty performing multiple tasks simultaneously, diminished attention and concentration, diminished executive functions, diminished information processing, and diminished visual spatial abilities. So they have expanded the cognitive symptoms from the 6th to the 7th edition. Patterns of symptoms, looks like it's pretty much the same, varies greatly from person to person, varies over time in each individual affected. First symptoms usually transient, typically sensory and visual. And in the 7th edition it says and or visual. Diagnosis involves evidence of damage occurring at least 2 separate areas of the central nervous system and at 2 separate points in time at least 1 month apart. Dissemination of lesions in space and time. So that's the same. Affective symptoms, depression, anxiety, pseudo-mobiliar effect, and anxiety, motor symptoms, paresis, paralysis, fatigue, spasticity, spasms, ataxia, incoordination, intention tremor, postural tremor, impaired balancing gait, speech and swallowing, dysarthria, diminished verbal fluency, dysphonia, dysphagia, bladder symptoms, spastic bladder, flaccid bladder, dyssynergic bladder, constipation, diarrhea, and incontinence, sexual symptoms, impotence, decreased libido, impaired ability to achieve orgasm. Sensory symptoms at the top: hypoesthesia, numbness, paresthesia, tingling, etc. Pain, paroxysmal limb pain, dysesthesia, headache, optic or trigeminal neuritis, Lemurity sign, hyperpathia, chronic neuropathic pain, visual symptoms, blurred or double vision, diplopia, diminished acuity, loss of vision, scotoma, that's a little dot that flies in your eye, nystagmus, lateral gaze palsy. So it looks like the big difference between the 6th and the 7th editions, the cognitive symptoms have been expanded. And it said either and or on something else. Oh yeah, first symptoms usually transient, typically sensory and or visual, which over here it said typically sensory and visual. Okay, and now we're down to therapy ed. So I'm going to stop this video and upload it, and then we'll do a part 2 with the therapy ed slides, which is about 8 slides. Not much. Maybe I should just finish it. Yeah, let's go ahead and finish it. Okay, multiple sclerosis, a chronic, progressive, demyelinating disease of the central nervous system affecting mostly young adults. Etiology, unknown, most likely viral, autoimmune, active immune responses detected in the cerebral spinal fluid. Characteristics, demyelinating lesions, plaques, impair neurotransmission, cause nerves to fatigue rapidly. Variable symptoms, lesions scattered in time and place. Lesions common in pyramidal tract, dorsal columns, and periventricular areas of the cerebrum and cerebellar peduncles. Variable course with fluctuating periods, exacerbation, which are worsening of symptoms, and remissions, progressing to permanent dysfunction. Precipitating or exacerbating factors, infections, trauma, pregnancy, and stress. Transient worsening of symptoms, adverse reactions to heat, hyperventilation, dehydration, and fatigue. Categories of MS. Relapsing remitting MS, RRMS. Characterized by discrete attacks of neurological deficits, relapses, with either full or partial recovery, remission, and subsequent weeks or months. Periods between relapses are characterized by lack of disease progression. Affects approximately 85% of cases. Primary progressive MS, PPMS. Characterized by disease progression and deterioration in function from onset. Patients may experience modest fluctuations in neurological disability, but discrete attacks do not occur. Progressive, secondary progressive MS, SPMS, characterized by an initial relapsing, remitting course, followed by a change in a progressive course with a steady decline in function, with or without continued acute attacks. Then you have progressive relapsing MS, which is PRMS. Characterized by steady deterioration in disease from onset, similar to PPMS, but with occasional acute attacks. Intervals between attacks are characterized by continuing disease progression. Let's move this right here. Okay? And then you have clinically isolated syndrome, CIS, first episode of inflammatory demyelinating, demyelination in the CNS that could become MS if additional activity occurs, can progress to RRMS, relapsing remitting MS, which is characterized by discrete attacks of neurological deficits, relapses with either full or partial recovery, remission in subsequent weeks or months, with periods between relapses are characterized by lack of disease progression, affects approximately 85% of cases. Diagnostic tests include LPCSF, LP, I don't know what that means, cerebral spinal fluid, elevated gamma globulin, CT or MRI, myelogram, and EEG. Exam, history, symptoms, disease progression, functional deficits, cognitive affective status, mild to moderate cognitive impairment common, also euphoria, emotional dysregulation, communication, dysarthria and scanning speech common, dysphagia. 4. Range of motion, deformity, associated with disuse and inactivity, sensation, sensory symptoms common, paresthesia, hyperopathia, sensitivity to sensory stimuli, dysesthesia, abnormal sensations, trigeminal neuralgia, Hermite sign, electric shock-like sensation throughout the body produced by flexing the neck, vision, diplopia or blurred vision, common. Also, optic neuritis, sotoma, which is a blind spot, and nystagmus. Skin integrity and condition. Muscle tone, deep tendon reflexes. Spasticity and hyperreflexia are common. Pyramidal tract lesions. Muscle strength and control. Paresis is common if spasticity is severe. Manual muscle testing may be invalid. Coordination. Ataxia is common. Intention tremors, dysmetria, dysdiadochokinesia. I hate that word. Balance. Vestibular involvement common with vertigo, dizziness, unsteadiness, paroxysmal or sudden onset of symptoms. Gait. Ataxic gait is common. Fatigue. Number one complaint, common with high levels of activity as the day progresses. Aerobic capacity and endurance. Monitor vital signs, heart rate, blood pressure, respiratory rate, and breathing patterns. Examine for exertional symptoms and perceived exertion. Functional status. Functional mobility scale and activities of daily living. General health measures, self-report of physical and social function, general health and vitality, health status questionnaire, SF-36, environment, home, community, and work. Standardized test outcome measures for patients with MS. Expanded Disability Status Scale, EDSS, based on 8 functional central nervous system components. Pyramidal, cerebellar, brainstem, sensory, bowel and bladder, visual, cerebral, and other, completed by a physician or neurologist. MS Functional Composite, MSFC, a 21-item test of 3 different functional subtests, includes time 25-foot walk, 9-hole peg test, and spaced auditory serial addition test. Multiple sclerosis quality of life, MSQOL 54, multidimensional quality of life measure. Modified Fatigue Impact Scale, MFIS, a self-report 21-item measure that examines the effects of fatigue on physical, cognitive, and psychosocial functioning in people with MS. Scale for the assessment and rating of ataxia, SARA, a performance-based measure of ataxia that includes 8 tasks: gait, stance, sitting, speech disturbances, finger chase, finger nose, fast alternating hand movements, and heel shin slide. Dizziness Handicap Inventory, DHI. 25-item questionnaire that examines a person's perception of disability in 3 subscales: physical, emotional, and functional. Functional assessment of multiple sclerosis, FAMS, examines quality of life across 6 life domains: mobility, symptoms, emotional well-being, general contentment, thinking, fatigue, family, social well-being. Medical management. Immunosuppressant drugs treat acute flare-ups and shorten duration of episode. Adrenocorticotropic hormone, ACTH, and steroids, for example, prednisone, dexamethasone, betamethasone, methylprednisolone. Interferon drugs. Slow progression of disease, decrease symptoms. Avonex, Betaseron, Copazone. Symptomatic management of spasticity. Drugs like baclofen, diazepam, Valium, dantrolene, Dantrim, baclofen pump, phenoblock surgery. Systematic management of urinary problems, anticholinergic drugs. Physical therapy goals, outcomes, and interventions. Monitor changes associated with disease progression. Revise rehabilitation plan accordingly. Develop supervised maintenance program. Examine for signs of urinary tract infection, respiratory infection, which are common causes of death. Rehabilitation goals. Restorative, intensive, time-limited rehabilitation services designed to improve, stabilize patient status after a relapse. Functional maintenance, services designed to manage effects of progressive disease and prevent, minimize indirect impairments associated with disuse and inactivity. Maintain range of motion, prevent contracture, maintain skin integrity, free of decubitus ulcers and other injury, improve respiratory function, improve sensory awareness, sensory compensation to prevent injury, consider eye patching with diplopia, improve strength, improve motor control, coordination, teach tone reduction techniques, compensatory strategies, and safety. Improve postural control, symmetry, and balance, teach compensatory strategies and safety. Provide assistive devices for gait, locomotor training. Promote independence and functional mobility skills and ADLs. Supervise family home health aides in assisting patient. Promote maximum mobility in home and community. Provide appropriate mobility aids and adaptive equipment. Wheelchair use common. Anticipate changes. Rate of disease progression. Teach energy conservation techniques, activity pacing. Avoid participating exacerbations. Schedule therapy sessions during optimal times for function. Minimize fatigue. Establish schedule of rest and moderate exercise. Avoid stressors and overheating. Provide psychological and emotional support. Emphasize realistic expectations. Focus on maintaining abilities. Focus on remaining abilities. Provide patient, family, and caregiver education. Teach problem-solving skills. And emphasize coping skills. Okay, I'm going to pause here for a second. Okay, I wanted to go back to this slide. Dysmetria, coordination, ataxia is common. Intentional tremors, dysmetria, and dysdiadochokinesia. However you say that. Anyway, dysmetria. Down here. A lack of coordination of movement typified by the undershoot or overshoot of intended position with a hand, arm, leg, or eye. It is a type of ataxia. It can also include the inability to judge distance or scale. Hypermetria and hypometria are respectively overshooting and undershooting the intended position. So dysmetria, lack of coordination of movement to undershoot or overshoot of intended position of the hand, arm, leg, or eye. It's a type of ataxia. Dysdiadochokinesia, inability to perform rapid alternating movements. So I had to go find some definitions of those two words and insert them. Yes, I did. I had to do it. I just had to do it. That's it. That is it for 3-6 Friday, multiple sclerosis, O'Sullivan, and therapy ed. I'm almost caught up. Moving on to Saturday.